Dr. David Kutler from Cornell Medicine is here to share his extensive knowledge and expertise in this arena and to discuss the ways in which it specifically impacts individuals with FA. Thank you for being here, Dr. Kutler.
Hello?
We can hear you.
Guys, you can hear me? Hi. Well, thank you for very much for inviting me to talk today. It's really an honor and a privilege. I'm sorry I can't be with you guys, at camp, but I'm from New York here, so I hope you guys are all happy and healthy and safe. So my goal today is to talk to you a little bit about head and neck cancer in patients with Fanconi anemia. And basically, I entitled it what every parent and patient should know about Fanconi's anemia and head and neck cancer. So to start off, I'd like to talk a little bit about a case presentation or a patient presentation. And I think this presentation illustrates some very important points about head and neck cancer in a Fanconi anemia patient. So this is a patient, and I just so you know, I've changed a couple of the things, just for privacy issues. So this is a 33-year-old Fanconi anemia male who had a bone marrow transplant as a child, and he initially saw me about 10 years ago with a painful ulcer along the posterior aspect of his inner cheek, which we call the buccal region. The patient noticed this ulcer about 4 weeks previously. He was seen by his medical doctor at that time for this ulcer, and he was given antibiotics, but it didn't improve the problem. The patient was found to have, when I saw him, about a 2 centimeter or about an inch irregular mass along the left posterior cheek, kind of back where his molar teeth were. And when I touched it, it was painful to palpation. I did a biopsy of this mass, and this is done in the office, and it was positive for squamous cell carcinoma. I also felt his neck, and he had no palpable lymph nodes in the neck. So it hadn't spread to any of the lymph nodes, at least clinically. I discussed the options with the patient, and he decided to undergo surgery. We resected the posterior aspect of his inner cheek, and then we reconstructed that with a graft from his thigh. And we removed the lymph nodes in his neck, which we do via an incision in the neck. Luckily for him, all the tumor was removed completely. All the surgical margins were negative, and he had no lymph nodes spread. Because of the pretty small size of the tumor and it was completely removed, a decision was made that he didn't undergo radiation therapy or chemotherapy. He was followed closely every 3 months in my office. He would come up and see me. But when you look in his mouth, he had what's called leukoplakia, which are these white plaques, which are these precancerous lesions in the mouth, especially on his tongue. But they were very diffuse. In other words, they were all over his tongue. So the idea was to keep a very close eye on him. 3 years after surgery, he was doing well, but he then returned to my office with a small mass, again, in the tonsil region. Again, he had another biopsy, which was positive for cancer. He had a small resection of the tonsil with primary closure. That means everything was removed, and all the surgical margins were negative, and he had no further treatment at that time. Now, I've seen him for 10 years, and over the years, I've been following him closely with physical examination and scoping. Unfortunately, he kept developing additional superficial cancers along the palate, the base of tongue, the tonsil region on the other side, and he required multiple surgeries to remove these small tumors. He is now 10 years out from his original surgery, and he feels well. He has no cosmetic issues. He looks good. He's able to eat a normal diet without any problems. So I think the takeaway message from this patient that I've been treating is that obviously FA patients get head and neck cancer early in life. Careful evaluation is needed, and you really want to catch these cancers early. Obviously, it is much easier to treat a small cancer, both from curing the cancer as well as, not causing any problems for the patient. So it's much easier to remove a small cancer than it is to treat a big cancer. I would say that careful surveillance is needed for all Fanconi anemia patients, not only because they have one cancer, but they'll get other cancers in different areas of their mouth and throat, and that has to be carefully followed. And you have to treat the cancer appropriately based on the stage. For example, if it's a small cancer, you can treat it with surgery alone and nothing else. If it's a larger cancer, sometimes you'll need surgery and additional treatment, for example, radiation. And I'll talk all about this. So just as a little bit of an outline of the presentation, I'll talk a little bit about the prevalence of head and neck cancer in Fanconi anemia patients. I'll talk a little bit about the current treatment options. What are the differences between FA patients, and non-FA patients. I'll talk a little bit about emerging treatment options, like what's new out there that you should be thinking about if you're diagnosed with head and neck cancer. We'll talk why FA patients have such a high predisposition to developing head and neck cancer, and how does this cancer relate to other FA-associated malignancies. So for all of you who don't know anything about head and neck cancer is considered cancer of the mucosal linings of the upper air digestive tract. So if you think about your mouth and throat, from your lips all the way down to your esophagus, you have this pink lining in your mouth and throat, which is called mucosa. So squamous cell carcinoma of the head and neck is basically cancer of the lining of your mouth and throat. Now, you may think that it's just one type of cancer, but because the head and neck region is so complex and has different areas, it has very diverse involvement. For example, some people get cancer of the sinuses or the nasopharynx, which is the back of the nose. Some people get oral cavity cancer, which includes the tongue, the cheek, and the floor of the mouth underneath the tongue. There's something called oropharyngeal cancer, which is cancer of the tonsil and the back of the tongue, which is all the way back in the throat. You can also get cancer of the larynx, which is the voice box, and the hypopharynx, which is kind of the entrance to the esophagus. So all these different areas, even though they're all squamous cell carcinoma, have different treatments, different surgery, different prognoses. So it's important that the head and neck surgeon obviously knows the difference between these type of cancers. The prognosis, in other words, how people do, depends on a bunch of different factors. You have the size of the tumor, which we call the T stage or tumor stage. Obviously, the larger the tumor, the higher the stage. You also, these kind of cancers can spread to lymph nodes in the neck, and that's called the end stage or nodal stage. And then obviously the tumor, even though it's pretty rare, can spread distantly, and that's called the M stage. So all those, whether it's the size of the tumor, the number of lymph nodes, or the positivity of the lymph nodes, and whether it's spread distantly, all change the prognosis of how the patient's going to do. It's also important, as I said before, which subsite within the head and neck. For example, the hypopharynx, which is the lower part of the throat, has a much worse prognosis than, for example, the tonsil cancer, which is much better. There are other factors that the head and neck surgeon would evaluate, including perineural invasion, whether the tumor is invading the nerves, how deep it invades, called the depth of invasion, and then the interaction between, the tumor and your body and how that interface interacts all change the prognosis for the patient. So let's talk a little bit about the prevalence of FA-associated head and neck cancer. So the incidence of FA patients is much higher than the general population. If you compare it to the general population, Fanconi anemia patients have somewhere between a 500 to 750 increased rate of developing head and neck cancer, which is significant. And if you look at the incidence of getting cancer by your age, by the time a Fanconi anemia patient is 40, about 20% of those patients who are alive at 40 years old will develop head and neck cancer. So obviously, compared to the general population, which is 0.038%, it is 700, 500-fold increased risk, which is very significant. If you look at the characteristics of FA-associated cancer, You can see most of the FA patients are young, with a median age of 31 years. A lot of them are female compared to male. No one really knows why this is. And tobacco and alcohol is much less than the general population. My standard patient that I see in the office without Fanconi anemia are usually in their 50s to 70s. They're usually mostly males, and they're usually smokers, which is a significant risk factor for developing cancer. If you look at where Fanconi anemia patients get cancer, most of the cancers in Fanconi anemia are in the oral cavity, which includes the gums, the floor of mouth, and the tongue. Where in the general population, it's mostly the voice box, and that's basically due to smoking. So I think when you're examining yourself or doing self-examination, it's important to look in your oral cavity, which you can see in the mirror, and it's pretty easy to see. You can get cancer of other places, but they're much less likely. So how do you treat patients with head and neck cancer? And this is both for the general population and FA. So we have basically 3 ways we treat this type of cancer. Obviously, surgery, which usually includes removal of the tumor from the head and neck region, and then using an incision on the outside of the neck to remove the lymph nodes in the neck. Sometimes we can also use radiotherapy or radiation therapy, which is basically beams of radiation that are used to kind of shrink the tumor and kill the tumor cells. And obviously chemotherapy, which is usually drugs. And there's different types of chemotherapy, both targeted chemotherapy, immunotherapy, and then the standard, chemotherapy. But most of the time, especially in head and neck cancer, if the tumor is significant and has a higher stage, most of the time we'll use combined modality treatment, which means that we'll use surgery followed by radiation, sometimes surgery followed by radiation and chemotherapy. And all of that decision-making is done based on how aggressive the tumor is and how significant the tumor is in terms of its prognosis. So a head and neck cancer requires a lot of other people. So you have me, who's the surgical oncologist or the head and neck oncologist, but you also need a lot of other people in the hospital. And I'm probably one of the more popular people in the hospital, in my hospital, because I know everybody, because I have to work with everyone to give the best treatment for head and neck cancer patients. So you need radiation oncology to give the radiation, medical oncology to give the chemotherapy, endocrinology, nuclear medicine. You need the plastic surgery and reconstructive surgeon to help with reconstructing after you do a resection. You need a dentist and a prosthetic person to help with the teeth, especially since they're involved in the head and neck region. And of course, psychiatry, nutrition, nursing, diagnostic radiology, and pathology. So all these are very important. And I think what this really says is that if you get head and neck cancer and wherever you're treated, you really have to have all of these things to really treat you appropriately. So most of the big academic centers have them, but if unfortunately, if you go to a local hospital, they may not have, all of these things in order to give you the best care. So in terms of head and neck surgery, I'm not going to go into a lot of pictures or show you what the surgery is, but you can pretty much do surgery on any part of the head and neck region. There are different surgeries that we do for different parts of the head and neck. This is just some of the examples of the surgery that I do. Most of the time for Fanconi anemia patients, we're talking about some kind of oral cavity surgery. This is just an example, and this is a woman who basically had a total glossectomy, which means removal of her tongue. A total glossectomy means removal of the entire tongue. And you can see here, she had the surgery already, and it looks like she has a tongue in there. And that is a flap. In other words, we took part of her abdomen and we reconstructed her tongue so it looks like a tongue. And she can talk, eat, and swallow, even though I removed her tongue. And you can see here, this is a picture with her mouth open, you could see that it looks a little bit lighter than a regular tongue, but this is an example of how you can take something, a pretty significant surgery, and reconstruct it so they have good function, good speaking, and good cosmetic look to it. Let's talk a little bit about radiation therapy. So this paper was published a while ago. It looked at 12 Fanconi anemia patients. 7 were male and 5 were female who underwent radiation therapy after surgery. The average dose was a little bit lower at 52/42. Most people who get radiation after surgery, it's about 6,200. That's the dose of the radiation. Now, unfortunately, this was a long time ago, and a lot of people didn't understand how to treat Fanconi anemia patients with radiation, and a lot of these patients developed significant toxicity. They had high-grade mucositis, which means they had inflammation and irritation in their mouth. They had difficulty swallowing. Some of the FA patients who did not have a bone marrow transplant got pancytopenia, which means their blood counts went down, and they had to have blood and other type of medication to support their bone marrow. And they had other complications, which were bad complications, including swelling and stenosis or scarring. So it was very difficult for these initial 12 patients to have radiation. And if you look at all the data back when this was published, 5 of 12 cases, in other words, 5 of the 12 patients couldn't finish the radiation because of those severe complications. 8 of the 12 patients died after the radiation, and 4 of them during the course of the radiation. So I think what this says is that radiation is hard on Fanconi anemia patients. But to be quite honest, I have successfully radiated actually many patients at this point with Fanconi anemia. But what I want to leave you in terms of the radiation is that you should really reserve radiation for tumors that really need it. In other words, high stage tumors that are aggressive. In other words, if you have a small tumor that can be removed surgically and you don't need radiation, radiation should not be given in any sort of way. And I think if it is administered, in other words, you need the radiation, I think you should probably go to a physician who at least knows what Fanconi anemia is and understands the problems with doing radiation for Fanconi anemia patients. Chemotherapy is difficult for Fanconi anemia patients, and to be quite honest, I've only given a small number of patients chemotherapy. The standard chemotherapy for Fanconi, for head and neck cancer is something called cisplatin, which is here. Cisplatin is very toxic to Fanconi anemia patients, and it really cannot be given. There's unacceptable complications because of your underlying issue. Cetuximab or Erbitux is a different type of chemotherapy, which we call targeted chemotherapy. It is basically targets a receptor which helps treat the head and neck cancer. It has been given to several FA patients successfully. It does have a little more side effects than the standard person who gets Erbitux in terms of pancytopenia and dysphagia, which usually doesn't happen in the general population. The hope is that, if you develop head and neck cancer, you would find it relatively early and you wouldn't need radiation or chemotherapy, but there are times where patients do need all three, and it's important that the person who's treating you understands the difference between a Fanconi anemia patient and the general population. So how do people do with Fanconi anemia head and neck, Fanconi anemia associated head and neck cancer? Unfortunately, many of these patients don't do as well as we would like. About half had recurrence of their tumor within about 1 year or 10 months. So that means that they had treatment for their tumor and the tumor came back about half the time. Sometimes it came back locally, in other words, for example, in the oral cavity. Sometimes it came back in the lymph nodes in the neck, and one patient, at least in this study, it spread distantly. The problem that I have as someone who treats Fanconi anemia patients even if you do a good job with a small tumor, they can still recur local regionally, as I showed you in our in the patient that I presented initially. So even small tumors, stage 1 tumors, a percentage of them will recur. So this is why you need very close follow-up. About 73% died from all causes when you had head and neck cancer, and 58% of the patients died with disease. If you look at the overall survival, and this means like the 2-year overall survival and the 5-year overall survival, Fanconi anemia, which is this purple line, has a worse prognosis in terms of survival compared to the general population, which is this red line. And this is over many months. The other problem that we have is that, many of these patients with Fanconi anemia, once they develop one cancer, they have a very high rate of developing another cancer during their lifetime. And this is one of the initial studies. About 63% of the patients developed multiple malignancies during their lifetime, which is very, very high compared to the general population. And in this study of about 19 patients, 5 patients actually within their lifetime developed more than 2 malignancies. And if you compare it to the general population, it's a very significant increase in the number of secondary cancers that develop. So what other things are coming out that everyone needs to be aware of in terms of treatment? And so what I tried to do is give you something new in terms of surgery, something new in terms of radiation, and something new in terms of reconstruction, as well as different chemotherapy. So I call this part emerging treatments. So as time has gone on, and this is over probably the last 10 years, the surgeons are going towards lesser surgery, I should say. So in other words, we want the same oncologic result. We want to cure the patients, but we want less invasive surgery. We want the surgeries to be smaller, but at the same time, do whatever we need to do in terms of the surgery. So one thing that's come out in the last 10 years or so is something called transoral robotic surgery. Some people just call it robotic surgery. Sometimes you'll hear it called TORS, T-O-R-S, which means transoral robotic surgery. This is what it looks like. It basically, the patient sits at a console, the surgeon sits at the console and he controls the robot, which is basically where the patient is. So, I would be under this console controlling the robotic arms, and the patient would be here, and these robotic arms would be in the mouth. This is an example of how how it works. I use these hand controllers on that console there, and you can see how small the arms are, and these arms fit into your mouth and allow the surgeon to basically remove tumors that are all the way in the back of the mouth that you can't get to without doing a very large surgery. The name of the robot is called the Da Vinci robot. It's made by a company called Intuitive. So this is just an example. This is just a still picture. Here's the robotic arm on this side. Here's a robotic grasper. I don't know if anyone, this is the uvula, which is the thing that sits in the back of your throat. So I'm all the way back at the very back of the throat. And you can see how well I can see back here. And by the good visualization and using these small robotic arms, I can successfully take out tumors just through the mouth, which I couldn't do before the advent of the robot. So, for someone who has a relatively small tumor in the back of the throat, instead of undergoing radiation, which is complicated for a Fanconi anemia patient, or a very large surgery, which is difficult to recover from, the surgeon can use the robot to get back there and cut out the tumor successfully. Obviously, one thing to say about the robot is that you have to be the right candidate to do the robot. You can't use it for every single surgery. So it's important that your surgeon is aware of these things. And if you do, or you are a candidate for robotic surgery, it would be useful to use. There's also improvements in reconstruction. This is an example. This is a patient who had a tumor in the jaw over here. You can see it over here. And this patient needs to have part of his jaw removed to remove the tumor. And then we also obviously want to reconstruct the jaw. And we can do all this surgery on the computer before we go to surgery. And we plan the entire surgery out on the computer first. And then we take that plan and then we do it in real life on the patient. This is just an example. You know, here is a company called Medical Modeling. And we basically give this company all the CT scans and x-rays. And they basically, we do the surgery on the computer in terms of planning the resection, where we want to make the cuts. This is an example of where we're going to make the cut on the mandible. And then we're going to use the patient's leg. You have an extra bone in your leg called the fibula, and we can use that bone to reconstruct the jaw, because you don't need that bone. You can do normal walking without having this bone. So we are able to take this bone. We have designed exactly where we're going to make the cuts on the bone. We also have even put little dental implants in the bone while it's still in the patient. And that allows us to basically plan this out by reconstructing almost half the jaw with the leg bone, which we call a fibula free flap. This is done by me and the plastic surgeon. And you can see here, these are just all of the examples that we get, so we can plan out exactly how we're going to do the reconstruction. We usually get a model that's sent to us before the surgery, so we know exactly what we're going to be doing. We also can shape these metal plates to kind of hold the bone in place. And you can see here, here's a three-dimensional version of where we're going to put the plate to hold the bone on. This is just more example. And here's this is the patient who had the tumor in his jaw. You can see that he had, or maybe you can't see, he had this part of his jaw removed and reconstructed with the fibula, which is the leg bone. And you can see he has pretty normal movement of his jaw, even though part of his jaw is his leg bone. So you can see we've definitely advanced in terms of reconstruction. We've advanced in terms of less invasive surgery. So the surgeries can be done without hurting the patient and also reconstructing them so they get back to their normal self. So let's talk about radiation. There is new types of radiation that's out there that's been around for a couple years. And I call it less toxic radiation. If someone, or you may have heard about something called proton radiation. Proton radiation is a different way to give radiation. Instead of using photons, which is the standard type of radiation, we use something called protons, which is basically, if you remember from chemistry, is like make up the nucleus, with the electrons, protons, and neutrons. It has unique physical properties in that the proton therapy has the ability, when you radiate, you can spare normal tissues that are not in the target. In other words, say you have a tumor that's relatively small and you just want to do radiation to that tumor without any radiation to the surrounding area. Proton therapy can make it easier for you to do that. And it basically helps preserve like normal tissue. Many people are starting to use it for head and neck cancer, even though it's not standard. But if someone needs radiation, you'll hear about proton therapy. And the idea is that you can increase the dose to the tumor and kill the tumor without damaging adjacent structures. For example, a spinal cord or eye. There's some thought that it has improved local control, in other words, killing the tumor, but it has less early and late toxic side effects compared to regular photon radiation. So it's something to just know about if you need radiation. In terms of targeted chemotherapy, there are many. Every year there's new medications that are coming out that have oncologic properties. In other words, they are able to kill tumors. There's epidermal growth factor receptor antibodies. One of the most famous ones is called Erbitux, which some Fanconi anemia patients have gotten. but there's many different ones that are coming out every year. There's something called an EGFR tyrosine kinase inhibitors. These basically inhibit different receptors that allow the tumor to grow. So by inhibiting them, you can basically turn off the tumor. There's also vascular endothelial growth factor receptors called VEGF-Rs. And these medications basically, I guess the way to say it is when you have a tumor, blood vessels need to go in there to supply the tumor. But if you can turn off the blood vessels, which these medications do, you can kill the tumor. You could basically starve the tumor. And then there are many others which you may hear about called mTOR or MET. There's IGFR receptors. These are all very complicated, and to be quite honest, this is the specialty of the medical oncologist. But needless to say, the hope is that if you catch the tumor early, you wouldn't need any type of chemotherapy, which is difficult. The new thing that's come out is something called immunotherapy, which is a very hot topic now in head and neck cancer. Immunotherapy basically allows your own body to attack the tumor. It basically stimulates your immune system. So it's something to think about when you have, it's usually used for patients who have metastatic distant metastases. So I guess the big question is, why do Fanconi anemia patients, get head and neck cancer? And this is a little bit controversial. The question is, we know that in the general population, these are the causes of head and neck cancer. The biggest one, obviously, is tobacco and alcohol, and it's usually the combination of the two. If you smoke a lot and drink a lot, the chance that you'll get a head and neck cancer is about 20-fold increased compared to if you don't smoke. Betel nut is a type of chewing tobacco that's done commonly in India. India has a very high rate of oral cavity cancer because they use a lot of this betel nut chewing tobacco, which causes problems. Viruses can cause head and neck cancer. For example, Epstein-Barr virus, which is called EBV, can cause nasopharyngeal cancer. HPV, which is called human papillomavirus, which you may have heard of, is frequently seen in patients who have tonsil cancer or base of tongue cancer. This HPV is a very hot topic in head and neck cancer, I'm seeing a lot of these patients in the general population who have HPV. Now, obviously, in the general population, there are predisposing syndromes. There's something called Lee-Fraumeni syndrome, where they have a P53 mutation. There's syndromes that have a P16 mutation, and then obviously Fanconi anemia. So just to kind of push home the tobacco and alcohol, and that means that, because Fanconi anemia patients have a very high rate of developing head and neck cancer because of Fanconi's anemia, it is very important that patients with Fanconi anemia don't drink or smoke significantly. If you look, never drinkers have a much less rate of head and neck cancer than people who drink more than 2 drinks per day. And if you add that to smoking, the highest rate of cancer, which is about 20-fold increased risk, is patients who have smoked more than 1 pack a day and have more than 2 drinks per day. And this is in the general population who don't have a predisposition to head and neck cancer. So you can imagine if a Fanconi anemia patient or an adult is drinking and smoking, that could be very bad for that patient. Other possible causes of FA-associated head and neck cancer, obviously, the underlying problem that Fanconi anemia patients have is a DNA repair problem or chromosome instability. Does this cause more mutations within the cells of the oral cavity? That's definitely a possibility. Many patients who have Fanconi anemia have bone marrow transplants, and there's been some recent data that bone marrow transplantation, these patients get head and neck cancer earlier in their life. Viruses are also thought, obviously there was some thought that human papillomavirus could also be associated with an increased rate of Fanconi anemia associated. And then of course there are unknown risk factors, including oral cavity environment. Some people have done studies about the biome or the microbiome of Fanconi anemia patients' mouths. In other words, what kind of bacteria they have in their oral cavity, which may predispose them to developing head and neck cancer. But most likely, to be quite honest, Fanconi anemia patients get head and neck cancer at a high rate because of multifactorial problems. It's probably a combination of the DNA repair problem, bone marrow transplantation, viruses, as well as unknown risk factors. So, this is something to think about. In terms of the chromosome instability, many patients with Fanconi anemia have pre-malignant lesions throughout their mouth. In other words, when you look at their mouth, they have changes in the lining of the mouth that are not normal. And these changes can sometimes basically be the start of developing oral cavity cancer. And not only oral cavity cancer, but anything in the upper air digestive tract. When you have these oral dysplastic lesions, there's an increased likelihood of progressing to squamous cell carcinoma. So what happens is you begin to have atypical cells in the mouth. They start to change and turn into like precancerous dysplastic cells, and then they go on to continue to change over time and then develop into cancer. And this is just some of the examples of what the cells look like, going from relatively normal to abnormal cells in the mouth. Now, why people progress from normal lining to carcinoma or oral cavity cancer, it's probably collecting different types of mutations. And if you look at some of the mutations we understand, you can see as you go from normal mucosa to carcinoma, the genetics or the genes become abnormal. There are mutations that occur, which then change the cells into cancer. As I said, I mentioned HPV as an example. HPV is a type of DNA virus. It's very common in the general population. About 85% of the patients have been exposed to HPV. And there is definitely some causal relationship between HPV and head and neck cancer. Many people feel it's a distinct disease. In the general population, even though the role of HPV in FA patients is controversial, it's an important factor in the general population. And all of you may or may not know that there is now a vaccine for HPV, and whether you're preventing, cervical cancer, which is also related to HPV, versus head and neck cancer, boys and girls, I think all of FA patients should probably get the HPV vaccine. So let's just talk a little bit about bone marrow transplant and cancer. If you have a transplant, the hazard or the risk of developing head and neck cancer is about 4.4-fold higher in patients who retrieved a bone marrow transplant than those who did not receive a bone marrow transplant. The head and neck cancer occurred in younger patients when they received the transplant, 18 versus 33 years. And if you look at, this is a study that I was involved in, you could see with a history of bone marrow transplant, the median age of developing a head and neck cancer was about 26. With no bone marrow transplant was about 35. Now, whether this was related to some other cause, or whether this is related to bone marrow transplant, this is the data. But it's something to think about. If you get a bone marrow transplant, your risk of developing the head and neck cancer may be higher. This is just an example, again, of the age of onset. Even though there were some outliers here, the age of onset was lower or less when you had a bone marrow transplant. Patients who have head and neck cancer also develop other cancers in other regions which may be similar. For example, several patients with head and neck cancer, especially in women, they develop anogenital cancers, which are also squamous cell carcinomas. And if you think about the mouth and the vagina, it's a very similar environment. So you can imagine that these patients both had the same type of cancers in different areas that are similar. There was some thought that viruses, for example, like HPV virus, may also be related to that as well. Skin cancers are also found in head and neck, in FA-associated head and neck cancers. Again, it's really exposure to the environment. and maybe obviously more mutations that are developing because of the underlying Fanconi anemia. Obviously, further discussion is needed to really see the associations. So in terms of like summing it up, I think in terms of treatment approaches and how to take care of patients with Fanconi anemia, early detection is extremely important. I think because people have difficulty with radiation as well as chemotherapy, surgery is the preferred treatment. But that being said, if you have a higher stage tumor, in other words, a larger tumor, you probably will need surgery plus radiation and sometimes chemotherapy as well. Obviously, there will be new treatments coming out that are non-DNA damaging, which potentially can be used in Fanconi anemia patients. And when you get a head and neck cancer, especially patients with FA, you need very close surveillance in order to make sure that you don't get a second tumor in the oral cavity or any other tumor, for example, in the anogenital region. So I want to thank you all. I think I used up all my time, and I'm happy to answer any questions that they have.
Hi, Dr. Kutler. Nice to see you, and thank you very much for being here. I know it's a tough topic to probably present and to hear. We do have quite a few questions.
Yeah.
And the first one is regarding the studies that you referenced. So do you anticipate any new studies on the incidence and outcomes, given that the ones referenced seem to be quite old? And also, are these studies referenced from the US only? Are they international as well?
Well, the study that I reference are US, but there are other studies which basically show similar. There's also, I think, I'm still collecting, again, it takes a very long time because the rarity of FA-associated head and neck cancer. So I'm planning on releasing or publishing another radiation paper, which is going to be coming out with like double the number of patients. And I think it will be a little bit helpful for patients with that.
Okay, thank you for that. We have a couple questions about the HPV. So how helpful is the vaccination in numbers? If you are able to give numbers, they're asking.
Yeah, I don't have any numbers. Obviously, even with the general population, we don't have the numbers of whether, the vaccine is really going to help for head and neck cancer. There's been a lot of studies trying to determine whether the vaccine, like what we would need to do to evaluate whether the vaccine works for head and neck cancer. You need about 25 years of studying patients because you get the virus very early on and you don't get the cancer later. So in order to really follow the patients who got the vaccine, you need many, many decades to basically look at it. So, but I think what you could say is that in the general population, HPV is definitely a causal factor for certain types of head and neck cancer, and the vaccine has very little side effects. So I would say that if it's a risk for some head and neck cancers and you can get the vaccine, I don't think there's any harm in getting the vaccine for HPV. It also helps with cervical cancer as well.
Okay, thank you. The next questions are regarding bone marrow transplant. If you've been transplanted, do you need to revaccinate? And is there a best timing for that? Additionally, is there any difference in the age recommendation for vaccination between male and female, regardless of bone marrow transplant?
Yeah, in terms of male versus female, they should be the same. I think that most people should get vaccinated somewhere before they have sexual relations. So we're talking like somewhere between 12 and 14 years old, to be quite honest. Most people are getting vaccinated. And there used to be, it was only FDA approved for vaccinating women to prevent cervical cancer, but now they're saying you could vaccinate boys as well. And this is over about 5 or 6 years. And you can vaccinate up to the age of 40 at this point. That's what they say, somewhere between 12 and 40 can be vaccinated for HPV. In terms of bone marrow transplant, HPV, those studies, I don't know of any studies that look at that, so I don't have an answer to that question.
Okay, sorry about that lapse. Just trying to group these in a succinct manner
No, I understand.
as they come in. So our next question is asking, are there blood tests or tumor markers that could indicate the existence of cancer?
I wish, but no, there's no markers, blood markers. I think the most common one that people think of is something called PSA, which they use to find prostate cancer. But in head and neck cancer, unfortunately, there's no markers that exist in the blood. Some people are using swabs to look at saliva, but they're not standard yet, and they're not used in clinical practice. But I hope that, that would be amazing to have a marker in the blood, but at this point, it's all physical examination and symptomatology.
Sorry, our next question is, how can we inspect the areas that they can't see using a mirror? So let's say down below the throat. And how frequently do these areas need to be examined by patients?
Yeah, that's a very good question. I think it's very difficult for you to look inside your throat with a mirror. You can see probably the teeth, the floor of the mouth, maybe the tongue. But once you start getting further back, it's pretty difficult to do it. I think that's why you go to the doctor, to go basically examine those areas. I have a very bright light that sits on my head, and I can see all the way in there. I also have something called a flexible scope, which goes in the patient's nose, and I can look down in places that I can't see through the mouth. And I would say most of my Fanconi anemia patients that have had cancer, I see them every 3 months. I think patients who have not had cancer, I think they should be examined by their medical doctor, and they should look in the mouth. And maybe like every 6 months, they should see an ENT or someone that can look down there to make sure there's nothing that's hiding in the very depths of the throat.
And can you speak to how subsequent cancers are, or how they affect survival rate? Is there a shorter survival rate with ongoing recurrent cancers?
Yes. Obviously, the best shot to cure someone of cancer completely would be the first shot. And so that's why we take, when someone gets first diagnosed, we take it obviously very seriously. When it recurs, the prognosis goes down. And every time it recurs further, it goes down even further. And that has to do with, we start losing, there's only so much surgery we can do on someone's throat. There's only so much radiation we can give to one area. So I think it's very important, if you're going to catch these tumors early, to catch them early so you don't have that problem. So I think the answer is yes.
Okay, we have somebody listening that would like to ask their question. They have their hand raised. So Sean and or Allison, if you would like to ask your question, you can go ahead.
Hi, Dr. Kutler. This is Allison Breininger, Sean's wife. Sean's 41.
Hi, how are you?
And good, thank you. I just wanted to sort of speak to the fellow listeners here that I know that this is, for us, often the hardest session to attend. And so I just wanted to give a little bit of hope to people listening that Sean, who is 41, has had multiple cancers. I know that doesn't sound hopeful, but because he is checked every 3 months, as you recommend, they have all been caught when they were very small. He did have the tongue flap surgery and is able to eat and talk perfectly. Last year, he was diagnosed with throat cancer and it was not able to have surgery. And so, but he did undergo radiation and a little bit of chemo using Xeloda, and it was successfully obliterated and he recovered perfectly. So I just wanted to add a little bit of hope to the listeners that we've sort of been down lots of the different paths that you mentioned today, and Sean is doing really well, but we would recommend that a lot of that is he is very aware of his mouth. And also we have had to learn to advocate, because often the doctors have said it doesn't look like anything to us, but they have started to learn that Sean gets it and sees it long before it's something that might look like something to them. So just wanted to add that comment. Thank you.
Thank you, Allison. We really needed to hear that. And also just being self-advocates is so important. So thank you. Our next question is, can you speak to any availability of robotic surgeries in other countries, and specifically Italy or Portugal?
Yeah, I mean, I think every country, give or take, I guess westernized countries have robotic available. I mean, the United States, has a lot more robots per capita than the rest of the world, but there definitely are people who do robotic surgery in Portugal and Italy. The question is, you need to be a good candidate for it. I mean, so someone who, you can't just go on a robot and say, we're going to take this, do surgery on you. So you need it has to be the right tumor and the right location to use the robot. But the bottom line is, yes, there are in Italy and Portugal.
Okay, thank you. We have a question. I believe what's being asked is, can pancytopenia and head and neck cancer exist at the same time, or does one affect the other maybe? I can read the question verbatim.
Yeah,
Let's
sure,
see if
sure.
that helps. I know patients with FA have a high risk of developing head and neck cancer, but I want to know if it's possible to have pancytopenia and head and neck cancer at the same time. Have you ever had a case with this combination?
Yes. Most of the time I've seen pancytopenia and head and neck cancer secondary to the radiation. In other words, the patient's getting radiation, especially if they haven't had a bone marrow transplant. Sometimes they will develop pancytopenia, and we have to kind of slow down the radiation for these patients in order for them to get through it. So yes, I've seen that, but I don't think they're related. Like the pancytopenia, I don't think causes the head and neck cancer.
Okay. Our next question is about chemoprevention, and wondering if there were quercetin lozenges that were used regularly, could these possibly help prevent cancers of the mouth? And just if you have anything more on chemoprevention in general.
Yeah. What was the lozenge? I'm sorry.
Quercetin.
Okay. Yeah. I mean, as far in terms of what's available out there, there's not a lot of chemoprevention medications that prevent you from getting head and neck cancer. I have to be honest with you. There's a lot of things that are, put out there as this is prevent cancer, but they haven't been really proved to work like that. There are many studies, and I was involved in one study looking at a drug that would basically prevent the dysplasia from turning into cancer. But it's not, these are all just experimental studies, and they haven't been used in general practice.
Okay, hopefully something in the near future.
Yes.
Yeah. So we have a question about what should be looked for in the mouth. What are the signs and symptoms or changes that can be visualized?
Yeah, that's a very good question. I think in former talks I've showed some pictures which didn't go over so well, but the bottom line is what usually they look for are if you look at the lining of your mouth, it's usually nice and shiny and smooth. Like if you look at your tongue in the mirror, it's usually pink and smooth, and there's no roughness to it. So cancer usually starts as kind of an irregular, like rough area on the tongue that doesn't go away, or it could be anywhere in the oral cavity. Usually it bleeds relatively easily, so if you touch it, it will bleed. It usually is slightly painful. Sometimes it looks like an ulcer, like almost like a very bad canker sore. But a canker sore usually just looks like a little white hole in your lining. This is actually usually bigger and uglier looking. And a lot of times it has an associated firmness to it. So if you feel it, it will feel thicker and firmer than normal. And that's what we usually look for. I usually look for either an ulcer or a mass that has a rough surface and usually associated with an ulcer. That's the best way I describe it. There are many different, pictures that I can show you, but the bottom line is it's something that is a lesion in your tongue or mouth that does not go away within 3 or 4 weeks.
Does it tend to be painful or not?
Yeah, sometimes they could be completely not painful. They're just basically a lump in the mouth. But I would say most of the time they're irritated. When they get larger, they can be very painful sometimes.
Okay, thank you. And we have another hand raised by Alejandra. She'd like to ask a question.
Sure.
Hi, doctor. My question is, I'm a FA adult patient and I'm on danazol, and the head and neck cancer is a big issue for me because I think I'm scared about that. So
Sure.
that's why I think like, do I have a high risk because I have pancytopenic and I'm on danazol. So I don't know if I can also develop this type of cancer.
Yeah, I mean, obviously, I think, unfortunately, I think Fanconi anemia patients have a high rate of developing the cancer. I don't think it's from the danazol, or, I think it's from the underlying Fanconi anemia. How old are you, Alejandra?
34. I'm 34.
Right. So I mean, the bottom line is I have patients, who I know who are 50 who've never developed head and neck cancer. And then unfortunately, I've seen patients in their, younger who have developed. I think the important thing for you, and I think I've said this a couple times, is you just want to make sure that, the ENT physician or head and neck surgeon that you're seeing or your medical doctors are keeping a close eye on your oral cavity so that if you do develop one, which I guess is a possibility, hope not, that you could take care of it relatively easily.
Okay, thank you.
And to be quite honest, Alejandro, I think a lot of people, and everyone can raise their hand if or whatever, virtually, is that, sometimes you go to the doctor and, maybe they don't know head and neck cancer or they have these lesions. Sometimes, they'll kind of say, oh yeah, it's nothing. But in a Fanconi anemia patient, you sometimes, have to take it a little more seriously. I think Sean had the same problem. They say, oh, it's probably nothing. And then it turns out to be something. So you just have to be a little more cognizant of what's going on with, you have to be your own best advocate.
Yes, definitely, it's true. But I was like, maybe because I have pancytopenic, I cannot develop another type of, cancer or something, but definitely it's just, we have to be aware of.
Yeah, I don't think the pancytopenia has anything to do with the head and neck cancer part. I don't think that, I guess you're saying it protects you or something. Yeah, I don't think that's correct.
Yeah, like I was thinking maybe you cannot have like the two things at the same time, but yeah, just thinking about it. But thank you so much.
Okay, nice to see you, Alejandro.
Nice to meet you.
I'm wondering, speaking about the androgens, is there any correlation between the incidence of androgen use and head and neck cancers?
Yeah, I mean, I think in the initial studies, they were trying to look at that, and there was no data to support that. But, again, the size of the population is relatively small. And not many people, I don't know what percentage are getting, bone marrow transplant. I think at the time there was a lot of, when I first started in the FA field, a lot of people were on androgens and less people were getting bone marrow transplant. And then as I kind of grew up, more people were getting bone marrow transplants.
Okay, thank you. We have Rena also raising her hand that would like to pose a question.
Yes, hello.
Hi.
My son was transplanted at age 8, 11 years ago. He's 20. He's doing well. His donor was his dad, so we didn't have to fight graft versus host. So I know transplant, you have a higher incidence of certain cancers, but what is the difference between transplant, having graft versus host, and not having it? How much of a difference? I mean, I know it's more likely with graft versus host, so I feel a little bit better protected. You know, you're looking for any silver lining. What do you have to say about that?
Yeah, I mean, I think there was a lot of thought, especially initially, that the head and neck cancers were somehow related to graft versus host disease. Because initially we were finding a lot of head and neck cancer in patients with those problems. I think that was a lot of people who were transplanted in Europe at the time, this is many, many years ago, had the graft versus host disease. But then, you know, those problems, as they improved the bone marrow transplant protocols, were less and less. In other words, less people were getting graft versus host disease from transplants. But I do think that it would probably, from a purely theoretical standpoint, it's probably better that he didn't get it.
Yes, thank you.
Okay, we have 2 questions from the same person, so 2 parts. One is, do some subtypes of FA have a higher incidence of cancer or higher risk of cancer? And then the second part is that her child's physician believes that the child is at a higher risk for getting brain cancer and wants to do an MRI. Can you speak to this and at what age it could happen?
What age, the brain cancer, you mean? Or,
yeah.
Well, I don't know. I mean, you know, in the initial study where we looked at the whole population, brain cancer was not a very common situation for Fanconi anemia patients. And I don't think it's a serious problem. I think head and neck cancer, I think vaginal cancer, anogenital cancers are a much bigger problem. Skin cancer, esophagus cancer, but I don't think that brain cancer is a big problem for patients with Fanconi anemia. I haven't, you know, seen a lot of these patients in the initial studies that were done. I don't think there's a very high rate. What was the second part or the first part of the question?
Are any of the subtypes of FA more at risk for getting cancer?
Yeah, I mean, we looked at this and there didn't seem to be any difference between the different colonization groups. I think it's a little bit of a confounding factor. In other words, it was a little bit confusing to look at the data. For example, you know, the Fanconi C patients, you know, had a much more severe early disease. And they were getting a lot of leukemias and having problems with that. While the Fanconi A, who had less, you know, a lesser phenotype, in other words, they weren't getting the leukemias and the pancytopenias, they lived longer, you know, and they were in their, you know, 30s and 40s, and then they were getting the head and neck cancer. So it was a little bit confusing in terms of, you know, where their biggest problem was in terms of, and the timing and the phenotype of the Fanconi anemia.
Okay, well, I think that's all of our questions. So unless we have any last minute hand raisers that would like to ask anything. Oh, well, one just popped up asking about childhood brain tumors in FANC-D.
I'm not familiar with that.
Yeah. Okay.
Oh, Blanchel.
Okay. Can we take that?
I had a quick one.
Oh, okay. Rena's back.
Sorry.
That's okay. Thank you.
I thought I saw one on the side. I wondered the same question as someone else posed, and sorry if you already answered this. With the HPV vaccination, my kids have had it, but somebody mentioned something about, does it ever have to be repeated, or there's a new one that's like, I
Right.
forget what the label is, but it's like no HPV ever. I don't know, some new vaccination.
Well, I mean, what they did with the vaccines initially, I mean, the most common HPV type that people get that causes head and neck cancer is called HPV type 16. There are other different subtypes that can cause cancer. So the newer vaccines have more subtypes included, in the vaccination. And in the general I don't know about Fanconi anemia, but in the general population, many people will get a booster after about a couple years. In other words, they'll get the first vaccine injection, and then they'll get a second one, and that helps with mounting an antibody response.
Okay, thank you. I think that's all our questions, Dr. Kutler. And again, thank you very much for your presentation. I know it's a hard one to hear, but we're very thankful for the care that you give patients that we send to you. So thank you very much.
Yeah, no, thank you all. And again, I hope I know I've given this talk a couple times, different versions of it. And I apologize if I scare people, but I just want you to understand, what I deal with, on a daily basis. And I do see a lot of Fanconi patients at this point, and it's better to know the facts, in my opinion, than not. And I think an educated patient is probably the one that really takes care of themselves better than an uneducated patient. So again, I apologize if I was a little blunt or I showed some difficult graphs to look at, but the bottom line is, I'm just trying to give you the information.
Absolutely. I think we understand that, and thank you. And as Allison said, when you're armed, you can advocate for yourself. So thanks very much.
Okay, nice to see you guys. Take care.